Hi everyone, this is Tim, your lecture instructor for the Paramedic to RN transition program. And today we're going to go over the cardiac system. I do know that this PowerPoint is about 51 slides long, and I know that it's very large and it's probably going to be very tedious, and you'll probably be tired of hearing me towards the end. But nevertheless, I am going to point out a lot of things that, or at least use the book to coincide with what we're looking at as far as the slides. And I do know that most of you guys have either heard of or seen these disease processes or even know exactly what to do as far as interventions. But I kind of like to point out the highlights and point out things that I find that are actually very important. And again, this is also to transition you, from being a paramedic out in the field to the patient that's being taken care of in the hospital. So, all right, here we go. All right, so the first disease process is coronary artery disease. Most common cause is atherosclerosis. It's an abnormal accumulation of lipids lining the arterial walls. Repetitious inflammatory response to injury. So basically this is your blood vessels constricting and dilating all the time, and when that happens, it actually causes trauma to the vessels, or at least the vessel wall. To repair that, your body will actually form not necessarily clots, but some sort of, let's call it a scab, if you want to call it that. And with that, cholesterol that's actually flowing throughout your bloodstream will collect to that, and that causes the arteries to actually narrow, because it's a buildup. Risk factors for atherosclerosis is age, gender, systolic blood pressure, smoking, diabetes, high LDL, and low HDL, your cholesterol. As far as let's probably stick with smoking and the diabetes. Smoking, because of the fact that it's a vasoconstrictor, and from what I've read, after about 10 hours of not smoking, nicotine is out of your system and your blood vessels actually start to dilate. Then when you decide to start smoking again, it will actually constrict them. So that dilation and constriction on a regular basis actually is what causes the trauma to the vessels. So that's why it's such a higher risk than anything else. Diabetes, because of the fact that it also causes inflammation and trauma to the actual blood vessels. Plus, if diabetes is not actually controlled, your blood gets thicker, and the thicker it is, the harder it is for it to actually circulate, which causes problems on the heart itself. And because of that, it has blood still flows, but it has a better chance of actually causing those, like I said, we call it a scab, and for the cholesterol to actually stick. So those two things are probably bigger risk factors than anything else. Prevention of atherosclerosis is control your cholesterol, because obviously if you lower your cholesterol, you have a better chance of you're not getting atherosclerosis. Diet, exercise are probably the two other biggest things. If you control what you eat and eat healthy, you're going to just automatically lower your cholesterol, and also keep things flowing and your blood nice and clean. Exercise, again, you're also going to keep things flowing nice and well. Medications will also prevent atherosclerosis. Again, stop smoking and manage your hypertension, because that hypertension and the blood pressure going up and down is what actually causes the trauma. The next disease process is angina. This can be sudden, and it's a response to exertion or emotions or extreme temperatures. There's a link here on the slide, and this actually takes you to a page that kind of describes angina a little bit better, or at least more in detail. I actually found that it to be very interesting and thought I'd share this with you. Angina can be described as a quality or severity. It's a squeezing, vice-like pain. Location and radiation. Location is usually substernal, or it may spread across the chest and the back and down the arms. The duration and relieving factors, usually it's the left side of the chest without radiation, and usually lasts less than 15 minutes. It's relieved with rest, nitrate medication, or oxygen therapy. The reason why, obviously, the nitro is a vasodilator, which allows more blood supply to the actual coronary arteries, and with oxygen therapy, it allows the blood to be rich in oxygen, and even if there is constriction or even blockage, at least your body's getting more oxygen, and it's actually making more use of it and becoming more efficient. Myocardial infarction is often sudden without precipitating factors and often in the early morning. And the reason why is because most people take their blood pressure medication, their cardiac meds, and their aspirin every morning. So by the time it wears off, it's the next morning, and usually it's before you wake up or as soon as you wake up. So by then, the medication has worn off. Here's another website that I had added to the slides, so that way you can get a little bit of a reading on this topic. The quality and the severity, usually it's an intense stabbing, it's vice-like pain, and usually the patient will feel pressure, and it's often severe. The location of the radiation, usually it's substernal, may spread throughout the anterior chest to the arms, jaw, back, and neck. And the duration and relieving factors are continuous or no chest discomfort, relieved with morphine because morphine is a vasodilator, cardiac drugs because it will actually help the heart beat a little bit faster, or hypertension medications because again it will also help dilate, and oxygen therapy because a little extra oxygen and it makes whatever is floating around there to be more efficient. Cardiovascular disease, its non-modifiable qualities are going to be age, gender, ethnic origin, and family history. You're born with these things, and based on your genetic makeup, these are things you cannot change. Modifiable things you can actually change, and what you should be teaching your patient is to change their lifestyle habits, become more physically active, lose some weight. And the psychological factor in all of this is that between stress, anger management, and depression, when you can't control those things, it causes a lot of stress on the heart. And again, stress causes, between the vasodilation and the vasoconstriction, it causes more problems on the arteries. And again, this also affects the heart itself. Your assessment is going to be patient history. You want to find out how they have been living for the last 20, 30, 40, 50, 60, 70 years. Were they a smoker? Did they have a lot of weight gain? Did they gain weight over a certain amount of time? You just want to kind of find out a little bit more about them and what has happened or gone on in their life, or even presently what's been going on in their life. You want to find out their nutritional history. Do they eat well? Do they eat a lot of junk food? Do they eat a lot of fast food stuff? Do they eat a lot of foods that contain salt, or do they add a lot of salt to their food? Current health problems. I've taken health histories from patients, and if you don't ask the right question, you don't get an answer. So these seem a lot of redundancy, but again, you're really trying to get to the bottom of what the problem is or how they got to this point. And find out their functional history. Can they walk? Can they exercise? Are they bound to a wheelchair? Are they bedbound? You kind of find out, what they physically can and cannot do. There's no point in taking someone who's severely obese and telling them to go to the gym and, run 5 miles when they couldn't even walk a mile. So kind of find out where and what they can do and kind of start from there. You also want to do a general appearance of the skin, extremities, vital signs, and the pulses, because again, the more you look at the patient, the more you kind of gather enough data, the more you find out information about them. On page 742, there is chart 27-6, which is an assessment assessing the acute coronary syndrome and acute myocardial infarction. So this is a pretty good way of trying to find out more information from your patient. And before I forget, I also wrote down 738, which is chart 27-3, which is the self-administration of nitro. This is actually a pretty good box to know, and the more information you take from this, the more you can actually teach your patient information about taking nitro, because a lot of these patients that will take it for angina won't be in the hospital, and they'll be able to carry it around their pocket, and they know when things aren't going well, or they actually need something to help to relieve the symptoms of angina. So definitely check that out. And on page 741 is managing angina pectoris. So it's again, these are more tips that you can teach your patient and kind of help them see the symptoms and what they should and shouldn't do, and when they need help or when they can actually care for it by themselves based on taking the nitro. So, all right, some more assessments on the cardiovascular disease, so or definitely myocardial infarction. So you're going to look at labs. A physician may actually order a troponin and a CK. These are both markers that if there's any stress in the heart, the stress in the heart will actually release a chemical, and the chemical will actually float around the bloodstream for about 24 hours. So for the troponin, you're actually going to draw it every 8 hours. Every 8 hours, if the troponin level keeps going up, then they indeed have had some sort of stress on the heart. It doesn't necessarily mean that they've had an MI, but it's a pretty good indicator. But if it trends up, then they can start doing more testing and looking in different areas. If it stays the same, then most likely they didn't have an MI because there wasn't enough stress on the heart to actually relieve this chemical. The creatinine kinase is, or the CKMB is for the heart muscle. Again, it releases a chemical based on the stress. CKBB, or that also does a chemical, but it's for brain tissue. Which the reason why I think I put this on here was more of the less oxygen that's going to the heart, especially the coronary arteries, the more stress it puts on the heart. The more stress that's put on the heart, the more it starts to affect other organs and body systems, and the brain is probably the next most important. So interventions, they're definitely going to do a cath lab and do a heart cath to find out what vessel is actually blocked and see if they actually have to put some sort of stent in it. Other interventions is thrombolytics. If there's actually some sort of clot that's actually in the coronary artery, that they'll put the patient either on some sort of blood thinning medication, or they'll actually put them on a thrombolytic and do it IV. Other assessments, you'll do diagnostic testing, which is the cardiac cath, just to see where the blockage is or the problem lies. They'll do EKG. They'll do a EP study, which is electrophysiology study. They'll do a stress test to find out if the more active your body becomes, if it's putting more stress on the heart, and at what degree. They'll do an echo to look at the heart and the as far as how it beats, and the ventricles, atrium, and to see how things are going. They'll also do a transesophageal echocardiogram, which they do go down through the throat and actually look at the heart. And they'll also do an MRI. Because of your history or your experience, I know you guys are pretty familiar with normal sinus rhythm, tachycardia, bradycardia, atrial fibrillation, ventricular tachycardia, and ventricular fibrillation. What I really want, I know you're familiar, but I just want to make sure that you kind of brush up on everything, just to kind of make sure that you know what you're looking at and what it really means. Other assessments, dysrhythmias may be asymptomatic. Always assess your patient. I had a patient this last weekend that was on a heart monitor, and the teletech kept calling me every hour or so to tell me that the patient was running some sort of funky rhythm. And instead of panicking, you really just kind of go down into the room, you look at the patient, and she's laying there watching TV and flipping through the channels. So a lot of times, if you adjust the tele leads, change the battery, I mean, a lot of times there's I wouldn't necessarily say that you shouldn't react to every time someone calls, but in the same sense too, the first thing you do is really look at the patient. The monitor is great to tell you what's going on, but if it doesn't seem right, then kind of collect more data just to really truly prove that there's something wrong, or to prove that there isn't anything wrong. Obtain the patient's past and current history, and the reason why is because if a patient has had an MI and didn't actually know it in the past, that will actually show up on EKGs. So if it does show up again and they tell you they've had one, or if it was something that was previous, or if you actually if you're really lucky, you can actually compare EKGs from the time that they were in the hospital in the past, and that way you can kind of tell, well, they didn't have this the last time, but now they're having it, and now you can kind of judge based on when it possibly could have happened. Other things you'll do is you'll do a set of vitals, which is blood pressure and pulse, oxygenation, and respirations. You'll do an EKG monitor because if a tele monitor only has 5 leads, but an EKG usually has 12, and it's a little more specific. And then you also want to, help your patient with the psychological impact of having an MI. They're already anxious and they're very fearful because, these are laymen that, people that don't really know exactly what's going on. They only know what either read or been told, or people that they know who have had one, and it's the unknown. So they're pretty anxious and fearful. Interventions are going to be drugs. They're going to do either hypertension medications or they'll do antidysrhythmics. Other things you can do for your patient is they can do vagal maneuvers. They can also place a pacer. They can do cardioversion, defibrillation, or radiofrequency catheter ablation. And I do know that these are also in the reading. And I do know that there's several chapters to read. And there's lots and lots of stuff to read. But again, this is more of you kind of going through and understanding a little more in depth, and definitely when you are studying and reading these things, keep more in mind of what the nurse is doing at the bedside. What interventions are they doing? Why are they doing them? And what is the expected outcome? So, all right, so let's see here. Heart failure. There's three different types of heart failure. So there's left-sided heart failure, right-sided heart failure, and high output failure. This is usually a ventricular problem. It's usually left ventricle first, and then both ventricles actually fail. So in a nutshell, basically, blood comes from the superior vena cava into the atrium, goes from the atrium into the ventricle, and the ventricle, if it's on the right-hand side, is not, doing well, and it actually doesn't push the blood out of the ventricle, and blood tends to back up. And we'll go over those symptoms of what that really means. And then again, on the left side, basically it's going from atrium to the ventricle, from ventricle to the lungs, and then from the lungs back into the atrium into the ventricle, and it's not actually pushing out. So then at that point, blood backs up into the lungs, and we'll talk about those symptoms. So let's see here, left versus right. Left-sided heart failure is usually caused by hypertension, coronary artery disease, and valve disease, which is the mitral valve or the aortic valve. Right-sided heart failure, the right ventricle cannot completely empty. Cardiac output and stroke volume. Cardiac output equals heart rate and stroke volume. Remember, muscle gets tighter, muscle gets bigger, and the ventricles will become dilated. So what this really means is that with heart failure, again, the heart itself is an actual muscle, and the stronger it, or the more it works, the stronger it gets. The stronger it gets, the bigger it gets, because again, it's a muscle. But this won't last very long, and eventually it actually gets tired, and then eventually it just stops. All right, so left-sided heart failure assessment. You're going to have a decreased cardiac output. Your patient is going to feel fatigued because blood is not pumping the way it should. They're going to feel weak because of this. They'll feel restless. They'll feel dizzy because their blood pressure isn't high and their heart rate isn't strong enough to actually push all that fluid throughout their body. They'll have weak peripheral pulses, and their extremities will be pallor and cool. Again, with left-sided, the blood that is oxygenated coming from the heart into the ventricles isn't actually able to push out. The patient will also have pulmonary congestion because of the fact that it's not pumping. They'll have a hacking cough, dyspnea, and breathless. They'll have crackles and wheezing because of the fluid buildup. They'll have frothy pink tinged sputum, and I think this is more of because of the congestion itself. Because of the fact that they're having a hacking cough, and also the alveoli itself is not able to infuse or transfuse the oxygenated blood and the deoxygenated blood, and they'll also have tachypnea. Right-sided heart failure, they'll have a jugular vein distension, they'll have anorexia, they'll have nausea, they'll have edema in the legs and the scrotum. I mentioned this in the past. Path least resistance, fluid will go wherever it can. The edema is in the legs because the fact that the blood is pumping, but the heart is not strong enough to pull it back up, and that's where the blood tends to pool. It'll also be the scrotum because of the fact that the scrotum is actually very loose tissue, and it can expand. So again, path least resistance. They'll have a distended abdomen, and this is probably more due to third spacing. Polyuria at night. This is because when you lay down and sleep, at this point you're laying flat, and everything as far as fluid is diffused throughout the entire body equally. Because of that, your kidneys are functioning better, and they'll actually filter more, and because of that, then you'll actually urinate more at night. The weight gain is because of the fluid volume buildup, and you'll have an increased blood pressure because your heart is trying to push all that fluid throughout your body. The psychosocial congestive heart failure is a slow process. You just didn't wake up one morning, all of a sudden you have it. This is a 20, 30, 40, 50, 60 year process. And with that comes anxiety and frustration. And the reason why is because patients who have CHF have to go through a lot of different type of medications to find one that really truly works. Then they have to kind of adjust the dosage to really make it work as well as it possibly can. And that's frustrating because you think that, oh, okay, this pill's going to work, and it doesn't. Or, wow, I'm actually starting to get the fluid off of my legs, and I'm no longer swollen. Wow, this must be working. And then the next day they're swollen again. So there's a lot of frustration with the fact that this is kind of a painful process to find out what works and what doesn't. The anxiety is the fact that you have CHF, and I think you wake up every morning not knowing that if this is the day or not. So, and that could be because of either fluid volume buildup, the fact that you can't breathe real well, or the fact that your heart is constantly pounding and it's trying to do the best that it possibly can. Because of that, you'll have increases shortness of breath, and then the depression because of the fact that what you used to be able to do, you no longer can do. You're going to assess the family for anxiety and depression also, because this is a disease that actually affects not only just the patient, but those who are actually help caring for them. So you want to help them and find out what services they need, or if there's any help, or sometimes if you really just stand still long enough and be quiet, they'll actually kind of tell you what they need and kind of open up to you a little bit and stuff. So but again, the patient's trying to be strong, the family's trying to be strong, and everybody's trying to get through this and try to do the best they can. Labs that you will look for, there's electrolyte imbalances. We mentioned Lasix and aldactone, water pills before. Those will pull the fluid off of the actual, the body and out of the vascular system, which is good. But then what, comes with those pills is, when you take a water pill and you start to pull the fluid off, salt and or sodium and potassium also follow. So if you're giving medications, find out what some of the side effects are, and you will find that a lot of them is sodium or potassium depletion. So you want to be able to look at those too, because if you're giving the pill to pull the fluid off, then you also want to make sure that you replace the sodium and the potassium, so that way it doesn't cause other issues. There's another lab called the BMP. When your patient has acute shortness of breath, this differentiates between the heart and the lung dysfunction. So the BMP allows you to find out if it's more of a respiratory or pulmonary issue based on the fluid buildup. You're also going to do your analysis and microalbuminuria. This is an early indication of heart failure. And albumin is more protein-based and because of muscle breakdown. So then you also do ABGs. You'll do an arterial blood gas, and just to find out how well they are breathing and how well what is in them as far as the oxygen is being transported and what their acid and base balances are. So images, they'll do a chest x-ray. This will determine if there's an enlarged heart, if there's hypertrophy or dilation. They'll do a radionuclide study. This is to determine left ventricular ejection fracture, and they'll also do an EKG. Nursing diagnosis or goals, it's to improve gas exchange. You want to be able to improve cardiac output, decrease fatigue and weakness in your patient, and prevent or managing pulmonary edema. So improve gas exchange, you can either do the Lasix or the dactactone to be able to pull the fluid off. The lungs, and if you can pull the fluid out and this allows them to breathe better, then the gas exchange will increase. You also want to do whatever you can to increase the cardiac output. So whether that is giving them some sort of water pill, giving them blood pressure medication, whether it's giving them some sort of anti-dose rhythmic to be able to make the heart beat more efficiently. Decrease in fatigue and weakness. These people tend to be very tired and weak based on the lack of either oxygen or the fact that their heart's not beating correctly. And you want to be able to get them to still move and get some sort of exercise, but in the same sense too, they also tire out very easily. So group things together. If you're going to go into the room and do certain things, then don't do them every hour. Kind of bundle them together so you can kind of go in, get it all done, and let them rest. Preventing or managing pulmonary edema, again, you're going to, do your assessment of listening to the heart and the lungs, making sure that they can breathe right. And you're also going to do what you can, whether it be medications, whether it be, send a spirometer, whatever you can to actually prevent them from having the pulmonary edema. Because again, these people are literally drowning in their lungs based on the fact that fluid is on them and they can't actually get it off. Other interventions, we mentioned drug therapy, O2 administration. You'll do vital signs to find out, how their blood pressure and pulse is. They'll do cardiac resynchronization therapy, ventricular assisted devices, and heart reduction surgery. So with all these disease processes, my theory is that in the next 10 to 15 years, nursing needs to become more community-based as opposed to hospital-based. And that's because the population, especially the baby boomers, are getting older and they're getting sicker. Or not really so much sicker. They're getting older, and because of that, they're either going to have age-related disease processes, or because of the fact they live so long, eventually things kind of wear out and they do get more disease processes. And the idea is to actually educate them as much as you possibly can. You will not be able to fix their congestive heart failure, but what you can do is actually teach them what signs and symptoms are of when the fluid is actually getting too much, or when they're having chest pain, what they should do, and if the nitro is not working, and what you should do at that point. So your job in the community is to really educate patients about their disease, what the symptoms are, what they could do at home, what they need to, when they actually need to call for help, and kind of, it's to keep them out of the hospital. Not because we don't want them, it's just more of, if your patient has CHF and it is exacerbated, and we're going to give them, Lasix every 12 hours and watch them, they could do that at home. So if you can actually educate them as far as what the medication's for, when to use it, when not to use it, things like that and stuff, it just makes things a little bit easier for them. Again, there's home care, it's the same concept, and then self-management. Again, if you can teach them what signs and symptoms are and what the disease is and what they can do to help themselves, then it just makes that better for them. The next disease process is hypertension. Normal blood pressure is 120/80. Hypertension is 140/90. This is not something this is not new to you guys. You actually have seen this in the field before. So the causes can be primary, which is family history, being African American, which is more ethnic hyperlipidemia, which is high cholesterol, smoking because it's a vasoconstrictor, age because your heart and your veins and arteries are wearing out. Sodium and caffeine tend to cause hypertension because with sodium comes water, and with caffeine comes vasoconstriction. Weight can cause hypertension, stress because of vasoconstriction, and then men versus women. So it's also gender-based. For your assessment, you're going to assess the risk factors, ask about headaches, dizziness, and fainting. The reason why is because people who have hypertension, especially extreme hypertension, will actually get headaches because of the one of the symptoms is the fact that the vasoconstriction and the actual pounding in their head, and there's too much going on up there, not enough space. You're going to do a set of vitals. You want to do orthostatics. Basically, you're going to do a set of vitals while the patient's laying down. You'll do a set while they're sitting, and then you'll actually do a set while they're standing. If there's actually a difference in 20 millimeter mercury systolic or 10 millimeter mercury diastolic, then they actually have orthostatics, which basically means they went from lying to standing and the blood pressure dropped and they got lightheaded and fell down. Interventions: teach the patient about lifestyle changes. Again, you want to actually teach them about, not smoking, lose some weight, eat healthier, exercise, restrict your sodium, just based on trying to keep the water weight off. You want to control the amount of alcohol that you drink. The more alcohol you do drink, because of the fact that it's alcohol, it actually it's a dehydrator, and that causes issues. Again, we mentioned exercising, do relaxation techniques, whether it be yoga or, reading or, watching TV. I mean, just whatever you can do to relax. Again, no smoking and caffeine because they're vasoconstrictors. Drug therapy is going to be hypertension medications and diuretics. Next disease process is peripheral artery disease. Disorders that change the natural flow of blood through the arteries, veins, and usually the legs. The causes are usually atherosclerosis, and that's blockage of the arteries from plaque causing the lack of oxygen and nutrients. So peripheral artery disease is the arteries in your legs tend to not have enough arterial blood flow, and that causes issues. And we'll talk about those. So your assessment, the patient's going to have resting pain, numbness and burning is usually in the toes, feet, and the heels, calves, and ankles. Again, the arterial blood is trying to get to them, and it's the furthest part of your body, but because of the either vasoconstriction or atherosclerosis, it's actually not allowing sufficient blood supply, and that's what causes the pain. Inflow disease, it's pain in the lower back, butt, and thighs. This causes the patient to stop walking. So basically at this point, it's gone from being more toes, feet, and ankles and calves to now being in the lower back, butt, and thighs. Because of the pain, your patient stops walking, and because of the lack of exercise or the lack of muscle movement, the blood supply and the actual circulation gets worse. Alflo's disease is burning and cramping of the calves, ankles, feet, and toes, may be relieved by rest. So it's kind of an opposite, but it's the same concept. Symptoms of peripheral arterial disease is hair loss on the lower calf, ankle, and feet. They tend to be dry, scaly, dusky, and pale and molten skin because obviously the oxygenated blood is not getting to where it needs to go. And this also will cause thickened nails. Severe arterial disease, extremities are cold, cyanotic, darkened, and there's actually muscle atrophy. So at that point, you're barely getting any circulation at all. Imaging, you're going to do an arteriograph. This is looking for narrowing of the arteries and occlusions. Interventions, you're going to palpate the pulses in both legs to find out if they're things that you will assess for is if you palpate both legs to find out if they're equal as far as in size and the temperature and the feeling. You're going to assess for ulcers, especially at the toes, because if there are ulcers, they're never going to heal because of the lack of blood supply. And teach the patient about intermittent claudication. So it's them actually getting good blood supply, then not getting it, and then getting it and not getting it. With peripheral arterial disease, this is arterial, so how do we get the blood flow to travel further down the leg? And those interventions are going to be exercise, elevate the feet, sit in a chair instead of lying in bed because of gravity. You're going to promote vasodilation, provide warmth because it's a vasodilator, but don't do it directly because you don't want to burn them. Because of the lack of circulation, they tend to be having lack of sensation, and if it is too hot, they won't know whether it's actually burning them. And if it burns them, they get an ulcer, and then more blisters, and it turns into an ulcer, and next thing you know, they're not going to be able to heal. So reduced exposure to cold because it actually vasoconstricts, and then stop smoking and don't drink caffeine because they also vasoconstrict, and then there's also drug therapy. Invasive procedures are going to be arterial revascularization, which means that they're going to go in, they're going to rotor all those out, and then that way you can get a better blood flow. They can do a bypass or they can do a thrombectomy. So if there is something actually occluding it, they can again go in and actually try to remove it. Arterial occlusions, there's the embolus, which is a blood clot that travels. Symptoms are pain, pallor, pulseless, paresthesia, paralysis, and poikilothermic, which I believe is coolness. So again, you actually kind of go from the peripheral artery disease to total arterial occlusions themselves, and that's where the symptoms come in. Interventions are going to be anticoagulant therapy, so whether it be Coumadin or heparin, whatever they can do to actually start breaking up that clot. You can do a thrombectomy or embolectomy, which is basically removing it. They'll do pain meds because it is very painful, and then you're going to actually assess the pulses because if it's totally occluded and let's say that the foot becomes cold, then they've now got to the point where it's going to start dying. Peripheral venous disease, PVD, veins are not operating properly. You'll find that there's not much difference in the sense of between peripheral artery disease and peripheral venous disease. The arterial disease is blood can't actually get down there to be able to, circulate and to nourish the extremities. And with peripheral venous disease, it has gone down there, it just can't come back up. So veins are not operating properly. Deoxygenated blood is not returning to the heart. Causes could be an actual DVT or deep vein thrombosis. Varicose veins, they're defective valves. So, there's valves and veins so that way blood doesn't actually backflow. And if they're defective, then blood is really essentially just pulling and not going anywhere. They also can have defective skeletal muscles, which means that those patients who either can't move or are not moving, or the circulation is not doing well. With exercise causes muscles to expand and contract, and that actually helps move blood around. And if they have got poor skeletal muscles, then it's not going to help at all. Causes of a DVT is hip therapy, total knee replacements, prostate surgery, ulcerative colitis, heart failure, cancer, oral contraceptives, and immobility. Your patients will have a higher risk of DVTs based on pretty much any surgery that they've actually had. Their body is designed to, you cut into them and they're going to want to clot and actually cause, scabbing and try to make sure that the body doesn't bleed to death. That's pretty much any surgery, and because of that, things can break off and either travel, and if they do, then they're going to get stuck in those very small microscopic veins. So that's where you get your DVT from. Health promotion for DVT is avoid oral contraceptives, drink plenty of fluids, because the more fluids you drink, the more hydrated you become, the more dilated your vessels are. This will help with blood going back to the heart. Exercise daily, especially the legs, because again, not only are you exercising and vasodilating vessels and moving the blood, but it's going to keep things moving a lot better. And then patient education, because again, these are layman people. They don't really know. They're just doing what they've been told or what they kind of know or what they've read off the internet. So you kind of have to educate them a little bit more and kind of keep them on some sort of path. Your assessment for DVT is going to be calf or groin pain. There's going to be some swelling because of the fact that the vein is occluded and blood can't come back to the heart. You have a positive Hohmann sign. When I was in nursing school, we learned the positive Hohmann sign, which is basically flexing your feet up to the ceiling. We're now finding out that that doesn't actually prove anything. You're going to compare the legs. If one leg is more swollen than the other, or if it's painful, or if it has less sensation, then you probably have a DVT in one but not the other. You also want to check for warmth. You're going to check for edema because things are going to start to swell, and you're also looking for redness. Diagnosis, you're going to do your assessment. You'll do an ultrasound of the legs or any veins to find out if there is an occlusion, because you can actually have an occlusion in your legs and your arms, and you can have an occlusion anywhere, but the most common is usually the legs. But they'll do an ultrasound to find out, or even a Doppler to find out if there's actually an occlusion. There's partial occlusions and there's complete occlusions too. They'll do an MRI. The Ddimer is actually a lab that they will take. It's if your body has a clot in it, one of the chemicals that is released from the clot is a Ddimer. Interventions, you're going to do rest, and I know it sounds kind of stupid. You want them to be able to exercise based on having peripheral vascular disease or arterial vascular disease, based on keeping the body and the circulatory system working as efficiently as possible. But when you actually have a DVT, you want them to rest. You want them to be in bed rest. You don't want them moving around. You don't want to apply warmth, and you don't want to massage the legs, because the more the vein, if the vein was completely occluded and then all of a sudden you vasodilated that vein as much as it possibly could, which is now bigger than the actual clot itself, that clot can actually break and then it'll go somewhere else. So you can actually turn it from a DVT to an actual PE or an actual stroke. So you want to try to do whatever you can to not necessarily vasodilate because of the fear of breaking that clot. You'll do drug therapy, which is anticoagulants, and with those, whether it be Coumadin or heparin, there's actually certain labs to determine whether or not their blood is too thin or too thick and whether the med's working. So you want to know your labs. Other interventions is surgical management, so they'll actually go in and remove the clot itself, and then there's also venous insufficiency, so you want to kind of be careful that once they do remove it, then it becomes a surgical wound, and at that point you have to watch whether or not it truly heals and whether or not the surgery is successful. And I did all those slides in 40 minutes, so it was actually pretty good. I felt that I talked pretty fast most of the time, but again, these were really just the highlights. I pointed out a couple pages as far as things that I want you to know. Again, I've mentioned this on all the other voiceovers. Read your chapters first. Go through the actual voiceover PowerPoint. Kind of compare the two. And again, take what the nursing interventions are, why we're actually doing them, and what we're looking for as a result. And I think you'll be fine.